A very good evening, everyone. We'll start our session in a couple of minutes. Good evening, ma'am. We'll start with our session, ma'am.
Yeah, I think if the panelists are available, we can start with
Yes,
the case
ma'am.
presentation. Yeah. Okay, so are you going to set the context?
Yes, ma'am. So, a very good evening, everyone. A warm welcome to all the esteemed faculty members, panelists, and participants who has joined today's academic session. We are delighted to host the IAIO Case-Based Discussion Lung Cancer organized by IAIO under the esteemed guidance of Dr. Nitya ma'am from VS Hospitals, Chennai. Ma'am, over to you, please.
Thank you. Thank you for the kind introduction. And this is our second in the series of a case-based discussion on various cancers that we commonly see in practice. So today we have our discussion on stage 3 non-small cell lung cancer, which is now increasing in incidence because of the better diagnosis and earlier diagnosis. Earlier, we used to see a lot of stage 4 disease, but now we have a lot of stage 3 disease as well. And because of varied experiences across the globe, we are not able to arrive at a consensus of what is right. And in the era of immunotherapy, I think we should really be discussing about what is right and appropriate for the patients. So today we have our speaker Dr. Vaishnavi Joshi. She'll be joining us soon, and we have our esteemed panelist Dr. Sendil Kumar, who's a senior consultant surgical oncologist at Madras Medical Mission Chennai. Dr. Sendil is widely recognized for surgical proficiency across a range of cancers and his active contribution to surgical oncology, education and training. I'm proud to say that he's a colleague with me at VS and a wonderful academician as well. We also have Dr. Karthik Subramanian Tyagarajan, a consultant radiation oncologist at VS Hospitals. He specializes in precision radiotherapy and is actively involved in advancing multidisciplinary cancer care. Welcome, doctor. We're proud to have you here. Dr. Ritika Minia, assistant professor in the uh, Department of Pathology at All India Institute of Medical Sciences. With her academic background and diagnostic expertise, Dr. Minia plays a key role in both clinical pathology services and medical education. Welcome, doctor. We're proud to have you here, and we're looking forward to your insights on the pathological aspects of NSCLC. So we have a lot of case presentations from postgraduates today, and I'm eagerly looking forward to listening to them and trying to find out how we can optimize the treatment of in stage 3 non-small cell lung cancer in today's setting. So I think can go ahead with the first case presentation. The first case will be Dr. Neelam. Um, Over to you, doctor.
Good evening, everyone. Is my screen visible?
Yes, Dr. Neelam,
Yes,
you can
doctor, it is
continue.
visible. Please proceed.
Yes. Good evening, everyone. I'm Dr. Neelam, currently working at Sanac Cancer Institute, Bombay. I've recently finished my DM Medical Oncology from Cancer Institute, Adyar. Today we are going to have a case discussion on, I'll be basically on locally small cell lung cancer. I'll be basically focusing on the unresectable non-small cell lung cancer stage 3. What we were doing, what are can we do, and what are the new recent advancements. So to start with the first case, so this is a 65-year-old gentleman, current smoker, presented with history of cough with expectoration and breathlessness. So a PET-CT was done that showed a left lung mass with hilar and bilateral mediastinal lymph nodes, and there was no evidence of distant metastasis. MRI brain also showed no evidence of any brain mets. We did EBUS and a bronchoscopic biopsy that showed adenocarcinoma, TTF1 positive, and the contralateral lymph node was also positive for adenocarcinoma cells. So it was a clinical T2N3M0 stage 3 non-small cell lung cancer with a bilateral multi-station bulky mediastinal lymph node. So here, as we see in the PET-CTs, there is a large hilar mass on the left side. So the RT opinion was taken, and since it was difficult to achieve a dose constraint for organs at risk during radiation, so going ahead with an MDT discussion, we planned for a sequential chemotherapy followed by radiotherapy. So, as we know that stage 3 NSCLC is a heterogeneous group, so we can broadly classify that into three categories. One that is resectable, second that is borderline resectable, and the third is the unresectable, which I'll be basically focusing on today. So, what are the questions that we will be addressing subsequently? So, the pre-immunotherapy era, what we used to do, the era, the recent, all the new evidences that we have, the probable answers to some practical questions, and then what is the future direction. So, a brief history on the concurrent chemoradiation that we used to do in the unresectable NSCLC prior in the pre-immunotherapy era. So we know the by Oprin et al. This study, as we see that there is a clear benefit that was seen with concurrent chemoradiation compared to the sequential chemoradiation. And as you see, there's an absolute overall survival benefit from 2 years with 5.3% and subsequently at 4.5% at 5 years. So yes, they tried a lot of other. So there was RTOG 0617 where they tried comparing concurrent chemoradiation with sequential. There was and also they also tried doing dose escalation. There were also arms that included cetuximab, but it was all of these strategies did not show any survival benefit over the concurrent chemoradiation. So as we see in this trial, so prior to the immunotherapy usage, there were some subsets of the stage 4 that had all the mutations positive, and the survival was certainly better in the stage 4 compared to stage 3B. And this actually makes us think that yes, with the addition of immunotherapy, how we will be able to increase the survival for this subset of patients. So, with the advent of immunotherapy, as we know, the Pacific trial that included the unresectable stage 3 NSCLC patients who had received concurrent chemoradiation who were more than 18 with a BMS of 0 to 1, and all the patients were put post concurrent chemoradiation in two arms. It's durvalumab versus placebo. So durvalumab, that was given for 1 year with a placebo, and there was total 713 patients who were randomized, and here we clearly see that there was a clear survival benefit that was seen with the addition of durvalumab in the post CTRT setting. And as we see, even at 5 years, there is a continuous survival benefit of almost 42.9% in the durvalumab. So here we see that there's a median overall survival of almost 47.5 months that we can see with the durvalumab arm. So what are the questions? So that's what is the benefit of durvalumab after the sequential CTRT? So what is the ideal duration of the consolidation durvalumab? If we incorporate durvalumab as a concurrent radiation sensitizer, and does consolidation durvalumab work in the oncogene addicted non-small cell lung cancer? So yes, with the question, what is the benefit of durvalumab? So yes, this is a Pacific 5 that is trying to answer what is the particular question, where they enrolled all the unresectable stage 3 NSCLC, and they had given all the patients with a sequential CTRT or a concurrent chemo-RT. Both the patients were included, and they were randomized to 2:1 with. But in this, durvalumab and the placebo arm, and the durvalumab was given till the and the primary endpoints were PFS and OS. So here also, as we see that there is a PFS benefit of 14 months that is seen with in the durvalumab with versus 6.5 months that is seen with the placebo. So, and this is the slide that shows the PFS benefit that is seen with concurrent chemoradiation. And here, as we see that there is a benefit that is seen in the durvalumab arm, but somehow the benefit is similar to the Pacific regimen. So there is a question that is there really any benefit of indefinite durvalumab? And this in the sequential chemoradiation, as we see that there is late censoring that is seen. So query, shall we consider starting with an immunotherapy and chemotherapy, and then we can subsequently consolidate with RT? So these are some questions that maybe we can think upon. Then going to the Pacific 2 trial, where they had incorporated in the same stage unresectable site, where they had incorporated immunotherapy durvalumab along with the chemoradiation versus placebo, and it also had a endpoint of progression-free survival and overall survival. And as we see, even in this, there was a clear survival benefit that was seen in the durvalumab arm with a 13.8 months and 9.4 months in the placebo. And also in the overall survival, there was a benefit in the durvalumab with 36.4 months in the durvalumab arm with a 29 months in the placebo arm. So yes, in this patient, the patient continued to receive the chemotherapy followed by radiation, and he tolerated the treatment well. So the patient was started on maintenance durvalumab, and currently the patient is in clinical and radiological remission, as we can see in the PET-CT images as well. So going to the second case, so this is a 55-year-old lady who's a never smoker, presented with a history of cough with expectoration and breathlessness. A PET-CT showed a right hilar mass with a bilateral mediastinal lymph nodes. MRI brain, there was no brain mets. Biopsy showed adenocarcinoma TTF1 positive. So it was a clinical T2, M3, M0 with a bilateral mediastinal lymph node. And then the patient was started on concurrent chemoradiation, and then the NGS report was done that showed an EGFR exon 19 deletion positive with a PDL1 of 50%. So here, discussing about the LAURA study, where they had included the patients, so all the NSCLC unresectable patients who had an exon 19 and deletion positive with L858R, and it included both the patients post sequential or concurrent chemoradiation, and the patients were randomized to 2:1. So in the osimertinib arm, and the second was a placebo arm, and they were stratified with concurrent versus sequential, stage 3A versus stage 3B or C, and also China versus the non-China population. So here, as we see, also that in this study, the crossover was allowed, and the patient who progressed were allowed to cross over to the osimertinib arm. And the primary endpoints was PFS, and the secondary endpoint was OFS with what was the CNS progression-free survival and the safety. So here, so from where did we get the rationale for the indefinite dose? So it is the adjuvant trial that had actually given adjuvant gefitinib. So as we can see in this curve, that even after 24 months, the DFS curves, it begins to converge, and they're meeting by the 36 months. Even in this select trial, as we see with the adjuvant erlotinib, so after the 24 months, the DFS curves begins to converge and tail by the 48 months. So here, even in the Aurora trial, so we see at 36 months, there is a sharp drop in the DFS curve. A sharp drip is something that we can see over here as well. So here in the LAURA study, we can clearly see that there is a clear progression-free survival benefit with the addition of osimertinib with the 39.1 months versus 5.6 months in the placebo arm. And the time to CNS progression-free survival is also clearly, it is 9% versus 36%. Even the incidence of distant metastasis at 12 months was 11% versus 37%. And at the ELCC updated data of LAURA, we can see that there continues to be a time to first subsequent treatment survival benefit with addition of osimertinib with around 43.8 months in the osimertinib arm, whereas in the placebo it was 9.5. And also in the PFS2, we can see there is 48.2 months of survival benefit with the osimertinib arm. And here also we can see in the updated survival data, so there is clear benefit of 70% benefit as we can see with the osimertinib arm compared to placebo, that is 52%. So as we can see our patients, so this is the image that was done in May, and this May 2024. So this is the image of August, and then subsequently in April 2025 that we see there is a significant reduction in the size of the mass that was seen post starting of osimertinib. So there are a few questions that we need to address. So is this trial an unmet need? Is there a good scientific rationale for the experimental arm? Was the study design appropriate and the control arm standard of care? Were the endpoints justified? And did the trial meet its primary endpoint? And can we take this study as a practice-changing trial? So maybe we can have a discussion on all these questions with our panelists. So talking a bit about how we should really go ahead and treat the NSCLC. So obviously a word on resectable NSCLC. So yes, an MDT discussion is surely required involving the surgeon, radiation oncologist, pathologist, with also inclusion of pulmonologist. So this is something that I would like to show, that this slide shows that how there is the TNM 9th edition. They have included this N2 single station with N2 multi-station, and this subsite that has potentially resectable, and how we are moving towards the perioperative setting. We are moving towards the perioperative trials and perioperative treatment for the resectable patients. And these are the trials that Keynote 671 and all, Checkmate 770T, that is showing that is shown survival benefit with the use of perioperative approach. And yes, we have a long way to go. And with this, thank you so much for the patient hearing.
Thank you, Dr. Neelam. That was so extensive, lovely cases. Both the cases were very pertinent to our discussion today. And I'm really happy that you brought up all the clinical trials that were very relevant to the current case. And yes, I think the unresectable NSCLC forms a bulk of the stage 3 disease. And many of us do not really have, we are clueless because we discussed about durvalumab and osimertinib. Both
Yes,
of them
ma'am.
are very expensive drugs, and many of our patients are not able to actually go ahead and take the durvalumab maintenance, even if they are able to afford the perioperative durvalumab. But as evidence goes, as oncologists, we've got to discuss what is evidence-based, and definitely
Yes, ma'am.
both drugs have an excellent survival benefit when given in the right setting. Especially the osimertinib trial, it has just come out and it's been presented recently. There was a huge increase in survival when you look at the final outcomes, and the drug is here to stay, because earlier when I
Yes,
was
ma'am.
we never used to look at EGFR inhibition and anything less than stage 4. So we are looking at giving a lot of EGFR inhibitors, and we know that the role of EGFR inhibition doesn't end with stage 4 and advanced NLCLC in a palliative setting. So the indications have slowly come to adjuvant and then neoadjuvant. Yes, durvalumab, expensive drug, but the first drug to actually have some first immunotherapy to have some perioperative and maintenance benefit in any cancer overall. I think we'll have a lot to discuss. I think we can just take note of all the questions and we can just go ahead with the next case, and we can have a nice discussion with the panelists when it comes to the questions.
Sure, ma'am.
So I think the next case is Dr. Santosh Reddy. Can we have your slides, doctor? I think we'll just stick to the time. That's also important because there are many cases today.
Hello, ma'am. You can hear me, right?
Yes, doctor, please proceed. You can start your presentation. Your slides are visible as well.
Yeah, slides are visible, right? Yeah, ma'am. First of all,
Start the
good evening.
presentation. Yeah.
Yeah, first of all, good evening, and thank you for giving me this opportunity. And as Dr. Neelam has given the foundational basics of unresectable stage 3 lung cancer, now I'm going to present one case, a real world case. So this is the first case. Like initially, when I entered into Odisha, where I did my DM medical oncology. So this is the first case, like a journey of hope, durable response to durvalumab in stage 3 non-small cell lung cancer. So coming to the details, patient, a 56 years old male, he was failed by profession. He presented initially with dry cough,
Doctor,
breathlessness on
I will have to
exertion.
interrupt. Doctor, I will have to interrupt. I think the slides aren't moving. Can you just start the slideshow?
Slideshow, ma'am. Yeah, it is a slideshow.
We
I
just
just
able to, yeah, yeah.
now
I
it's
think,
moving, right?
yeah, now it's okay.
Yeah. So he presented with dry cough, breathlessness on exertion, and pain over the right side of chest. So on taking the history, he had a history of cough incidence onset. It was progressive in nature over the past 1.5 months. A dyspnea incidence in onset and progressive over the past 1 month. He had no history of loss of weight, no history of hoarseness of voice, dysphagia, puffiness of face, edema of upper or lower limbs. So he has no comorbidities nor any family history of malignancy. But he had the addictions of smoking BDs 10 to 15 packs per day. He also had oral tobacco, pan and BT leaves giving habits, alcoholic, occasional habit. So on doing the CECT for X, you can see here there is huge mass, 7.6 into 9.1 centimeter mass in the right upper lobe, with which is infiltrating into the mediastinal pleura and right posterior wall of the trachea. So, and there were also few abnormal mediastinal lymph nodes, which were noted in the right upper and lower paratracheal subcarinal lymph nodes. The largest was basically around 2 into 1.3 centimeter. So it's initially like there was also a supraclavicular lymph node. So it was a P4 disease N3 because of supraclav lymph node, right? And the CCT abdomen and pelvis was normal, and MRA brain was also normal. Also, the patient subsequently underwent a biopsy from the lung mass, which initially has come as squamous cell without an IHC proven. After doing the IHC serum markers, it came to be adenocarcinoma with PTFN positive and NAPSIN A positive. So we did a PDL1, which was less than 1% with the IHC. A summary like he's a 56-year-old male smoker with clinically T4N3 disease, adenocarcinoma histology, and PDL1 was less than 1%. NGS we have done, no mutations were found. So it's a carcinoma lung T4N3 disease. The case was discussed in MTB, as we'll discuss all the cases in MTB. So he was not a surgical candidate in view of extensive primary tracheal and esophageal involvement. So the plan of treatment was induction chemotherapy followed by CTRT. And luckily, at the time, he was the first person in Odisha who was enrolled into the durvalumab trial in Pacific. So he received the induction chemotherapy, methotrexate carboplatin, 3 cycles, followed by CTRT with the IGRT technique. And after the CTRT, he had a partial response, and then he was enrolled into a durvalumab clinical trial. He was lucky enough to enroll into the trial. So he received durvalumab 10 mg per kg every 2 weekly. So as you can see from cycle 1 to cycle 10. So after doing the cycle 10 again, he had PET CT. In the PET CT, the lesion size was decreased to around 67% from the initial CT scan. It was a partial response, and there was a residual disease after the 10 cycles of durvalumab. And then the patient has continued the durvalumab because as he was there in the clinical trial. So we gave him like from cycle 11 to cycle 20. After finishing the 20 cycles of durvalumab, the patient had stable disease, but after finishing the 20 cycles, the patient was lost on follow-up. Like we tried to call him, but he was lost to follow-up after the finishing of 20 cycles of durvalumab. So yeah, this was a real-world case where the patient has received CTRT followed by durvalumab maintenance. He was lucky enough; he was enrolled in the clinical trial. So I sincerely thank Dr. Professor Ghanshyam Vishwas, my mentor, who was my mentor, for his constant guidance throughout my career, and for the IOA team for giving me this opportunity. Thank you.
Thank you, doctor. That was a very nice case discussion, and it also reiterates the fact that perioperative chemotherapy with maintenance is the way to go in any patient who has access to durvalumab, considering that a lot of trials have, or a lot of trials as well as evidence. Yes, the Pacific trial was very important in this, and many of us, I think, were a part of the trial. It was a landmark trial, and it created a revolution because it was the first immunotherapy to really gain some importance in the perioperative setting, or in the non-metastatic setting. So thank you very much for this presentation. It was really good that you had collected all the details really well and given us a wonderful presentation. If you have any questions to the panelists, keep them ready so that we can, once we start our panel discussion with the expert panelists, we'll be able to answer them. Thank you, doctor. Thank you so much.
Thank you, ma'am. Thank you.
So our next case will be Dr. Kiran. I think, are you ready with the case?
Yes, ma'am. I'll share, ma'am.
Start sharing your screen. Yes, thank you so much.
Ma'am, my screen visible, ma'am?
Yes, doctor, it's visible. You can just start the slideshow so that it keeps moving. Yeah, thank you so much.
Good evening, everyone, and thanks for the organizer for the opportunity. Actually, I'll just ask an apology, ma'am, because there is a slight deviation from my side. I'll be presenting actually a stage 4 NSCLC. When one of our patient where NGS was very important for the treatment. I'll just proceed, ma'am. Background, lung cancer, as we know, is one of the second most common cancer in India. Adenocarcinoma is the most common among all lung cancers. EGFR, ALK and ROS, one are the commonest mutations seen, and we have seen multiple TKs have been approved in this thing. Here we'll see the importance of NGS. Here present a lady, homemaker, lady, never smoker, presented with left-sided chest pain of duration of 2 months, dyspnea and exertion 2 months, associated with loss of appetite and loss of weight, no comorbids. She was perfectly fit, ECOG PS1, HRCT thorax done outside, suggestive of soft tissue mass in the left upper lobe of lung with gross left pleural effusion. Diagnostic and therapeutic pleural tap was done, which showed positive for malignancy pleural cytology. Biopsy suggestive of adenocarcinoma, TTF1 positive, NAPSIN A positive. We did a PET scan, PET CT suggestive of primary in the left lung with upfront metastasis in liver, lymph node, and vertebral. Upfront CMRI brain was done. There was no parenchymal disease, so there is no metastasis ruled out. Initial NGS were on osimertinib in November 2020, along with denosumab 4-weekly. She did well with osimertinib, but were two oligoprogressions, one in brain and one in bone, which were treated with local therapy, that is RT. But she started to progress and have symptoms in Jan 2024, osimertinib, and continues denosumab. Post 4 cycles PEM-carbo, she was put on PEM maintenance. 4 more cycles she received. Again, she reprogressed. At that time, we biopsied her, rebiopsied progression. She was put on ERB with HER2 amplification gain of 21 along P53 and RB1. This was with EGFR elite fighter, multiple mutation like PIK3CA, P53, RB1. Amplification. She was counseled for TDXD became available. We started on TDXD. Post 2 cycles, immediately we assessed because it was expensive drug. There was some response. Post 4 cycles, again partial response. Currently, she continues to receive TDXD for the past 6 months with good clinical response and regular follow-up. This as a discussion part, NGS plays a good, valuable role in treating stage 4 cancer, which identifies 10 to 15% of additional mutations, actionable mutations, and in adult patients with unresectable metastatic NSCLC who activates HER2 mutation or amplification, TDXD is FDA approved, and TDM1 is a category 2 recommendation. Our in-house experience, where we have data of 145 plus patients of adenocarcinoma lung, 92% of the patients were stage 4, with 54% of them adenocarcinoma lung patient have targetable mutations. Targetable mutations matters a lot, wherein we can see here the median PFS was 15 months in the those patients who have targetable mutation subset versus 5 months in negative mutation subset, and median OS was 22 months in the targetable mutation positive subset versus 9 months in the negative subset. And NGS, in those patients who in whom EGFR AL cross wild type, NGS can be considered. Conclusion: it is wise to choose therapy, especially in the metastatic setting, wherein targeted therapy will have good responses and lesser toxicity compared to cytotoxic chemotherapy, which will have an impact on quality of life of the patient subset. Thank you.
Thank you, Doctor. I think that was a good case report on how NGS is actually important. We're finding out many additional mutations also with the advent of newer antibody drug conjugates like TDXD, as in your case. So this is also pertinent in patients with an earlier stage 3 NSCLC, and they're not eligible for surgery, where they've received just concurrent chemoradiation along with perioperative or without perioperative therapy and follow-up. So these patients, I think, initially, if we don't do an NGS because they are not advanced disease, and we'll really have to do a repeat biopsy and find out if they have any activating mutations. So thank you so much, Doctor. That was a nice case discussion, giving the importance of NGS testing in NSCLC, which is I think the most important malignancy for which NGS has extensively developed, and most of the mutations are really important to identify some kind of targets for these patients. The outcomes have really improved. When we were postgraduates, we never looked at survival for more than a year. We had just Geftinib, and erlotinib had just started its journey without even any generics available. So I think we've come a long way to giving perioperative therapy for most of these patients and expecting a very long-term outcome even without a surgery. So thank you, doctor. That was a very interesting case. Thank you for your presentation. I think we'll go to the next case, Dr. Anju. I think is she ready with her case? She can start sharing her screen if she's ready.
Our team is sharing, ma'am. Just a moment.
Yeah. Okay. Okay.
Am I audible, ma'am?
Yes, doctor. Please go ahead. Yeah.
Yeah, very good evening, everywhere. Just I prepared within a few hours this case, and thank you. You are accepted. My case is lung adenocarcinoma with the neuroendocrine differentiation. We revealed that by immunohistochemistry. The case is 60-year-old male with history of cough expectoration for a 2 month and change in voice last 1 month. Patient have also a history of weakness, malaise for a 1 month, and patient have a history of body smoking 20 packs per year. On radiological examination revealed a mass lesion approximate 10 centimeter and upper lobe of left lobe of lung, and we received 5 core of lung biopsy in our laboratory, and we found approximate size 0.5 to 0.1 to 0.5 centimeter in length, and 3 core are including only fibrocollagenous tissue and 1 core show only lymphoid tissue. Only 1 core show tumor, that is approximate contain 80% portion of the core, and the core is revealed presence of tumor in presence cord, nest, and small seat, and the tumor show moderate nuclear pleomorphism, vesicular chromatin, prominent nucleoli, intranuclear inclusion with a moderate amount of vesicular chromatin. Along with, we found 5 to 6 mitotic figure per high power field. In addition, the tumor cell nest are surrounded with desmoplastic reaction. Histomorphology suggests as an adenocarcinoma, and as a first report is given as the adenocarcinoma. Then we performed immunohistochemistry, and we found Ki67 is strongly positive in 100% cells, and synaptophysin also positive, cytoplasmic granular and nuclear 90% cases, and chromogranin also positive in cytoplasmic in 70% cases, and Ki67 and P40 negative totally. So finally, case is diagnosed as the adenocarcinoma lung with neuroendocrine differentiation. As in the figure, we can see that is the core comprising showing 80% portion of tumor. Here we can see that the cores and nest and infiltrating tumor, and they're surrounded with desmoplastic reaction. Here we can see this is a moderate nucleopleomorphism, vesicular chromatin, prominent nucleoli, and intranuclear inclusion. On an IHC, please show the slides. This is the immunohistochemistry picture, and first figure is showing the Ki67. Here we can see Ki67, and B figure showing the synaptophysin, and C figure is showing chromogranin. Here, so finally case is labeled as the LINET. In discussion, the WHO classification 2015 is giving importance of IHC diagnosis on a small biopsy, but it was not included in a 2000 WHO classification 2021 because that is mostly based on the molecular classification. So I have some questions for the panelist. What is the frequency and incidence of LINET for the non-small carcinoma of the lung, and what is the therapeutic target for the LINET, and what are the therapeutic response of these patients than the other non-small cell carcinoma of lung, and what is the prognosis of these patients in comparison to the other type of the non-small cell carcinoma of lung. So these are the points, ma'am, for my discussion for the panelist, ma'am.
Thank you, doctor. I think it is important that we still maintain pathology and immunohistochemistry in today's molecular classification. There are a lot of other unusual types and different kinds of pathological presentations, which may also have a different response to a clinical response to therapy as well. Thank you
Yes,
so much
ma'am.
for putting together this case so quickly and bringing to us a very unusual subtype of lung cancer. We don't see neuroendocrine tumors so frequently. I think most of us will agree. It's not a very common subtype to see something with neuroendocrine features in lung cancer. So it also has a very important implication because they might differ in the kind of molecular abnormalities that they have. The response to therapy, we know that in neuroendocrine tumors is not the same as that of the regular adenocarcinoma or other subtypes of carcinoma per se. I will also, leave this to the panelists to see how much this can be salvaged in the non-metastatic setting, because that's what we're discussing about right now. In our experience, in my experience, a neuroendocrine tumor of the lung, we've seen a pure carcinoid that is very common in presentation, and there are some patients who have a neuroendocrine differentiation in the middle of a proper adenocarcinoma per se, and
Okay,
there
ma'am.
might be an aberrant expression of all the neuroendocrine markers. So if there is an adenocarcinoma predominant, then I think we go ahead and treat them as a routine NSCLC adeno. And if there is a pure neuroendocrine differentiation, we'll also have to look at whether it's a small cell. So we go for a review and go full-fledged for the markers as well. So thank you for bringing up this case, and we really appreciate. I think Dr. Ritika will be able to give some more information on how the incidence of the neuroendocrine differentiation is present in NSCLC. Can we have your opinion, doctor?
Good evening, ma'am. Thank you. I'm honored to be here. Yeah, so actually, this is a rare subset of non-small cell lung carcinoma or overall lung carcinomas that we have, and the incidence is quite, like only 2 to 3% of subsets that we have seen over in our experience, and they really behave differently, and the prognosis and all is also different as related to that of other carcinomas. And basically, the morphology is the one that mostly differentiates. And the IHC, as she has already highlighted, that the markers that chromogranin and synaptophysin taken, and the peculiar appearance of the chromatin, all that is that helps us in the diagnosis. Yeah.
Thank you, ma'am. Thank you so much. How many of our, you are a pathologist. I mean, you see more number of patients and the subtypes per se. So for us, everyone is a mass and a node and a metastasis. So how do you think the molecular subtype varies in these kind of? Have you tried doing the molecular subtyping of such patients, and have you seen any difference in profiling for these peculiar subtypes?
Ma'am, as per our institute is concerned, we are very, in an infancy stage yet. However, in the previous years also, throughout my experience, haven't seen much of these. Like, it is a rarer subtypes, and this neuroendocrine subset is seen in multiple other tumors as well. So, more or less, they constitute a very less amount of the overall tumor subset. Yes. So rest, we haven't in our setup, we haven't seen quite many cases of this tumor as such.
Okay, thank you. I think, do we have any more cases? I think our case discussion is over, right?
Yes, ma'am.
Yeah. Okay. So has the speaker joined? She's available yet?
Ma'am is joining, ma'am. Connectivity issues there. Ma'am is trying to join.
Okay. Once she's there, I think let's finish our presentation, and finally we'll have the questions put to the panelists. So in the meantime, I would like to ask Dr. Karthik, how do you see the evolution of radiation in stage 3 NSCLC? Because in any of these stages, the resectable or the potentially resectable or the unresectable, all of which constitute the stage 3 NSCLC, what are the differences in radiation that you've seen over time? Because I think for us, everything was radical. So we are looking at more focused radiation nowadays. So I want your opinion on how the radiation, the paradigm has changed over a period of time. Dr. Karthik, please.
Yes, ma'am. So, a very good evening, everyone. First of all, I would like to thank man for the opportunity and all the doctors. It was a very wonderful and nice overall presentation. Got to know about a lot of cases here. So, as you rightly said, radiation paradigm has changed over time because initially in stage 3 NSCLC, we and as the first case that was presented, it is usually if it is a bulky disease or a disease that is gone to the opposite side, contralateral side, we usually suggest induction chemotherapy that is followed by radiation. But currently we're getting a lot of cases after chemotherapy that is being amenable for CCRT rather than before, because bulk of the disease is reduced, and so we're able to bring up the radiation field to a certain extent that is favorable for the patient. And one more point regarding radiation is that recently, with the addition of durvalumab, recently I treated a patient, one or two patients with durvalumab, and the response is quite very good, that we are able to even go for adaptive RT after a few days of radiation. That is, if suppose if it is definitive, we plan for 60 gray and 30 fractions. So if it is we make sure that we check the CT after 20 days or 25 days, and we see a wonderful response in the CT scan itself. So we are able to cone down the field so that the toxicity for the patient is reduced, making sure that the initial volume receives at least 45 to 50, after which the last 10 gray boost is received only to the remaining volume. So this is what that I didn't see before, because the bulk of the disease, if it is not reduced, then we'll have to, again, the toxicity will be more, so we'll ask to proceed with different lines of chemotherapy. Now we get a lot of patients.
So have you seen any added, with the advent of immunotherapy and all these drugs, have you seen any increase in toxicity for the radiation? Because there is a theoretical toxicity for the lung as well. So with many of the immunotherapies. So do you think that radiation adds to the prospective pulmonary toxicity that comes due to immunotherapy? So have you seen any increase in
definitely, compared to before, it is definitely 10 to 15% increase in toxicity is also seen, that we have gone to a point of giving a break in radiation also because of the toxicity. But going on all aggressive because it is stage 3 and we still are in the curative intent of radiation, we feel that it is okay to to add that much, at least 10% of toxicity, because the benefit is higher when compared to without adding. So toxicity is higher, but it is manageable.
So how is the setting in the resectable and the potentially resectable? So what will be your strategy in that kind of a scenario?
So if it is resectable, as far as lung is concerned and it is stage 3, our aim is to give it for optimized local control and give it to the surgeon for operating. So it should be amenable for surgery. So in this case, we make sure that the field is lesser and it is amenable for surgery. But if it's after surgery, post-operative, then definitely we have brought down the indications for post-operative RT because of the toxicity involved again.
Okay. So thank
Only
you, Dr.
very selected cases we choose the patients after surgery for radiation because the toxicity is very higher compared to pre-op.
How do you follow up these patients over a period of time? Because many of these patients are toggling between the surgeon and the radiation oncologist. The predominant follow-up is with them. So how do you follow up these patients over a period of time?
So if it is, as you rightly said, because it is between two primary physicians, so if it is stage 1, definitely the primary mode of treatment, the person follows up. But if it is stage 3 and the patient is willing to follow up with any one of us properly in a proper time interval of at least 3 months in the first year and then 6 months in the following years, then we leave it to them. But CT scan or any PET CT after the treatment is only 3 months after the final day of radiation.
Okay. So thank you so much, Dr. Karthik, for your insights. We'll come back to you again. And I'm happy to welcome Dr. Vaishnavi Joshi, who's our speaker for the day today. She's a senior consultant in medical oncology at Aster CMI Bangalore. And Dr. Joshi brings with her extensive clinical expertise in managing solid and hematological malignancies and is very known for her patient-centric approach and the commitment to evidence-based cancer care. I'm proud to say that I worked with her even as a postgraduate, and I'm so happy to hear her after so many years. So welcome, Dr. Vaishnavi. I think we would like to have your experience and your expertise in management of stage 3 NSCLC. I know it's a broad topic, so let's see how we can actually set up some kind of a take-home message for most of us present here today.
Thank you, Dr. Nitya, for this. Am I audible?
Yeah. Yes.
Yeah. Thank you, Dr. Nitya. Dr. Nitya, for she mentioned that she's worked, but she was a very inspiring senior in our MD days. So I'm very happy to be here. So since it's a broad topic, I'll restrict myself to a medical oncologist role. I won't step into the radiation and surgical aspects, but I will try to cover most aspects. So shall I share the screen?
Yes, you can start.
Yeah, 1 second. So my screen is visible?
Yes, it's visible.
Okay, thank you. So my topic for today is optimal management of stage 3 lung cancer. This topic ideally should be spoken by all the three specialities. So I'll try to, just touch upon a few factors here. I'll just talk on few clinical settings in stage 3 lung cancer. First of all, stage 3 lung cancer, for introduction, it's a very heterogeneous group. It includes multiple subsets to be treated with different modalities. So it should always be, we should always discuss with our surgical and radiation colleagues, and has to be done in a MDT kind of fashion. Upfront decision has to be done because of this heterogeneous population or heterogeneous subsets which are there in this stage 3 lung cancer. And the definition of stage, especially in the stage 3, is also evolving over time. So that's why it becomes even more challenging to bring out a single guideline for all these stage 3 lung cancer subsets. And the pre-treatment staging also has undergone reclassification, and we are doing, because in the PET era, CT era, mediastinal staging, all this has undergone evolution in the last 2-3 decades. And early studies which actually defined treatment for stage 3 lung cancer, they were inadequately powered, because now with major improvements in chemo and immunotherapy agents, and also refinements in radiation and surgical techniques, so this is a very challenging stage of disease where, all the three modalities, surgical, radiation, and chemotherapy, or medical oncologists should discuss extensively and arrive at a proper consensus for each patient. So this is the TNM staging. As we see here, if the stage 3 is defined, it can be T3, T4, or N2, N3, N2, N2A, and N2B. So these are the subsets, and with different presentations, how it has to be interpreted. So I'll just touch upon different clinical settings of stage 3 lung cancer and their management. So these clinical settings can be divided into: one is a T3N1 subset, second with disease with multiple tumor nodules in the same lobe or in the other lobe on the same lung, and T4N0 or N1. And the last subset is if you have decided if we have diagnosed a clinical stage 1 and 2 and operated, and then we have a pathological stage 3. So these are the 4 clinical subsets where we can, discuss treatment modalities. And again, it is complicated by the molecular subsets, so which is very important in defining and also strategizing our adjuvant treatments, whether these patients are EGFR, ALK and ROS positive or negative. So the most important or the most prognostic or the decision-making factor in stage 3 lung cancer is the mediastinal evaluation, especially with the PET and whether it's a radiological mediastinal involvement. If not, then if yes, then if the pathologically these lymph nodes are involved or not. In a country like India, where we have a high incidence of respiratory infections and TB, so this is a very important part of the staging, which actually defines the further treatment. So once we have the pathological confirmation of tumor involvement of enlarged mediastinal lymph nodes, whether the disease is potentially resectable. So this is the second criteria on which we decide our treatment. And if mediastinal lymph nodes are negative by pathological evaluation, and then the resection of primary tumor will be similar to stage 1 or stage 2 disease. If they are pathologically involved, then we go for bi or a trimodality treatment. And if patients do not have a suggestion of N2 or N3 lymph node involvement either by CT or a PET criteria, then it depends upon the T stage and the resectability. So invasive mediastinal staging is in central tumors is indicated in all these patients for potentially resectable T2, T3 and T4 tumors. And those patients on CT who have enlarged hilar lymph nodes or clinically N1 by PET. So also we need to do mediastinal staging. And there is a distinct subset, like when there is a peripheral T1 primary lesion, where this decision becomes controversial. So in these patients, role of preoperative pathological evaluation of mediastinal lymph nodes, and if there is no involvement of N1 or N2 or N3 disease on CT or PET criteria, here it is controversial. This is based on few guidelines I went through. Pardon me if I am wrong, anybody can add to this, but here it depends on the institutional guideline or institutional practice, where we can either go with a mediastinal staging or directly approach it with surgical intervention. So this is the NCCN guidelines for pre-treatment evaluation for NSCLC. If you can see here, the stage 3A and stage 3B, it mentions that molecular testing. So this is given high, this is a high priority because most of our adjuvant, neoadjuvant, perioperative, neoadjuvant chemoimmunotherapies depend on whether EGFR ALK is positive or not. So this takes high precedence or high, priority in our pre-treatment evaluation. PDL1 testing also, and bronchoscopy, pathological mediastinal lymph node evaluation. And of course, we all do a PET scan in these patients. MRI brain is also mentioned in NCCN guidelines. So this is the pre-treatment evaluation, and then we divide based on the nodes, whether they are involved, whether they are N1 or N2 or N3. Okay, so coming to the first subset, so T3N1 disease, if EGFR ALK negative. So right now, the strategy is to go for induction chemoimmunotherapy or perioperative chemoimmunotherapy, followed by surgical resection. again, if complete resection is not technically feasible. So this is something which we, decide upfront or at the end of chemoimmunotherapy. If technically not feasible, then concurrent chemoradiation should be followed by, should be the choice of treatment after the chemoimmunotherapy. So this, I think I've discussed earlier. Yeah, so coming to the next subset, that is, the patient may have multiple tumor nodules or satellite nodules in the same lobe as the primary tumor. So what do we do in these patients? Again, most of the guidelines recommend induction chemoimmunotherapy or perioperative immunotherapy and surgery as their initial treatment. If ipsilateral nodules in another lobe and negative mediastinal nodes, they can also be they can be candidates of the same approach, but the location and the extent of disease matters. So for example, we had a patient with a lesion in the upper lobe and a lower lobe. So then we had an MDT and discussed that this patient, pneumonectomy is the choice. So our surgeons felt that it may be difficult to resect in this particular patient. So location and extent of disease dictates the treatment in these patients. Coming to the third subset, that is T4 with N0 or N1 disease. So resectable, even with this, refinement in the surgical techniques, resectable T4, N1 or N0 lesions are uncommon. So most of these patients end up with definitive chemoradiation as for patients with mediastinal involvement. So surgery for T4 disease in a subset where there is presence of N2 involvement is contraindicated, or if an incomplete resection is inevitable. So this is the subset which is a controversial area, 3B, 3B, where we have to have an upfront discussion that these patients are going for surgery or not. So this is a distinct subset, but most of the guidelines mention T4 with N2 this subset surgery may be contraindicated. So coming to the last subset, clinical stage 1 or stage 2, we have done a complete evaluation, but the pathological stage turns out to be stage 3. So what do we do in these patients? Here we have multiple modalities. So it could be adjuvant chemotherapy. Later, depending on EGFR or ALK, you have adjuvant TKIs. And in those patients who are negative for these, we have adjuvant immunotherapies. And some of these patients with margin positivity and N2 disease, adjuvant RT also comes into play. I will just restrict myself to my own specialty and not speak about RT because of the scope of this discussion here. So this is the 3B and 3C as we discussed after the mediastinal or mediastinoscopy. If it is N3 negative, initial treatment as stage 1 or stage 3. If it is N3 positive, then it is definitive concurrent chemoradiation. So we have a patient who has undergone post-surgical or post-RT. What are the different settings in we consider chemo, TKIs? We have spoiled for choices for TKIs or perioperative or neoadjuvant chemoimmunotherapies. So how do we proceed? So with whatever we know we studied in our our super specialty studies was adjuvant chemotherapy. So I won't delve into this too much because we all know about this. So whom do we give? So most resected stage 2 and stage 3, one of the stage 1 subsets also, all are candidates for adjuvant chemotherapy. When do we give it? Ideally between 6 to 8 weeks post surgery. And what do we give? According to our Glaze meta-analysis, we all know platinum doublets with cisplatin, it could be vinorelbine, docetaxel, gemcitabine, or pemetrexed. All have the same efficacy, but pemetrexed had a better safety profile. So most of us with non-squamous, we prefer pemetrexed plus cisplatin as the platinum doublet for adjuvant chemotherapy. So what sequence do we do in sequence? I mean, if the patient requires chemo and radiation, how do we sequence this? If you go through all the trials and recommendations, actually sequence does not matter, but those patients whom chemotherapy is indicated, they recommend to complete the chemotherapy cycles and then go for radiation. So this is the sequence which is preferred. So after chemotherapy, coming to adjuvant TKIs, tyrosine kinase inhibitors. So what are the different recommendations? So the one which has the now with the very good data is the ADAURA trial which is a phase 3 double-blind trial. It had around 680 patients, stage 1 and 2, stage 3B. Adjuvant osimertinib, just 1 second. Yeah. So adjuvant osimertinib until recurrence or up to 3 years versus placebo improved 2-year DFS rates relative to placebo. Very impressive at hazard ratios. Benefits were maintained up to 44 months in this trial. So osimertinib is approved for adjuvant as adjuvant TKI for up to 3 years or till recurrence. So what about ALK positive tumors? Coming from the same date, the path with the ALK positive tumors, ALINA trial, again completely resected ALK positive NSCLC. So 2 years of adjuvant alectinib versus 4 cycles of platinum-based chemotherapy had a higher DFS at 2 years. But again, there is a caveat. Those who have received chemotherapy, what do we do, was not answered by this trial. But again, we just follow extrapolation from the other TKI trial and give them alectinib for up to 2 years. So what about patients who have undergone chemoradiation? I'm not going into details of chemoradiation and the chemotherapy regimens which we use, just going a little ahead. So the adjuvant osimertinib for post-CTRT also was studied, and then the median progression-free survival was quite impressive, around 39.1 months versus 5.6 months. So adjuvant, that is osimertinib after CTRT, is also recommended. What about patients who are target negative? So EGFR, ALK, and ROS we have checked and all are negative. So, and patient has undergone a surgery. So these are the adjuvant immunotherapies which are incorporated. So why we say that they are incorporated is we don't have any data for just adjuvant immunotherapies. These are the studies, these are the studies which incorporated immuno with chemotherapy, but we cannot give adjuvant immunotherapies in patients who have not received chemo. So the two important studies here, the IMpower 010 trial, improvements in DFS relative to best supportive care with atezolizumab following resection and platinum-based chemotherapy with tumors at least 5 centimeter or lymph node positive and PD-L1 expression. So this is important that with the IMpower trial, it was more than or equal to 1%. Coming to the pembrolizumab here, which was irrespective of PD-L1 expression. And again, similar patients, resected NSCLC, at least 4 centimeter T size or lymph node positive, irrespective of PD-L1 expression, because there was a greater magnitude of the benefit in the IMpower trial with PD-L1 more than or equal to 1%, which did not matter in this Keynote or Pearl 091 trial. So what about immunotherapy in those patients who have undergone CTRT? So we have the AGN trial here. Results, because there are so many trials, I've just included the results here. So this is the AGN trial which used those patients post concurrent chemoradiation not progressed. We use adjuvant durvalumab in these patients for near, and which showed EFS. EFS. Sorry, I think I missed this. That is the Pacific trial. I'm just going into this. Yeah, sorry. So I'm going to the neoadjuvant chemoimmunotherapy. So neoadjuvant chemoimmunotherapy, what are the trials which we have? So one which has been approved is the Checkmate 816 among about 350 patients, stage 1B to 3 resectable NSCLC. This is very important because EGFR and ALK genetic mutation should not be present in these patients. That's why it's important that we do this upfront. Addition of 3 cycles of nivolumab to neoadjuvant platinum doublet chemotherapy not only improved pathologic complete response rates, that is 24 versus 2.2%, also improved the EFS, that is median event-free survival with or without nivolumab was 32 versus 21 months with hazard ratio of 0.63. So this is one of the strategies which are I think in most of the subsets which I explained earlier, we use a neoadjuvant chemoimmunotherapy. This is one of the recommended strategy to do neoadjuvant chemoimmunotherapy, has shown benefit as far as pathological complete response is concerned, also event-free survival is concerned. So these were the results. So what about perioperative? So that is the neoadjuvant setting. Now coming to the perioperative chemoimmunotherapies. So perioperative chemoimmunotherapies, if you see the last 3 columns here. So there are 3 trials. One is the Keynote 671, AGN, and Checkmate 770. So 3 drugs studied here: Pembro, Durva, and nivolumab. So pembrolizumab was concurrently given with platinum-based chemotherapy for 4 cycles, followed by 1 year of Pembro. So all the 3 studies had 1 year of immunotherapy, whether it was Pembro, Durva, or adjuvant adjuvant nivolumab. Here, what we note here is none of them had any relation to PD-L1 status. It was irrespective, but EGFR and ALK had to be negative. And in the pembrolizumab and most of the durvalumab, that is the AGN study, only in the nivolumab study, that is the Checkmate 770, there were a percentage of EGFR ALK patients, and primary endpoints was EFS in all these studies, and EFS showed good hazard ratios. I'll just talk about the AGN here. It was a good EFS of 0.68, hazard ratio of 0.68. Pembrolizumab, it was 0.58 and 0.58 in the nivolumab. So all these studies showed good DFS or EFS data, but then OS data still in the pembrolizumab arm was 0.72. PCR rates was highest in 25% in the nivolumab arm, 17% in the durvalumab, and 18% in the pembrolizumab arm. So FDA approval is all there here. So these are the perioperative chemoimmunotherapy trials or studies. So what are the new studies which are coming up in this scenario? One is the NADIM or NADIM-2 study, which included a easier regimen that to give, which you commonly give preoperative paclitaxel, carboplatin, and nivolumab, followed by adjuvant nivolumab. Also showed an impressive PCR of 63% and 24-month progression-free survival of 95% in NADIM-2 study, which also confirmed improved PCR after when adding nivolumab. So this is one study which we are looking at. The other one is the NeoStar study, the phase 2 trial, compared neoadjuvant nivolumab alone versus nivolumab plus ipilimumab. This result is also coming up. LCMC3 phase 2 trial, where atezolizumab 2 doses were given pre-surgery, and acceptable safety MPR of 20% and PCR of 7%. There are other single-arm trials which are coming up. Atezolizumab or durvalumab combined with chemo pre-surgery. So these are the newer studies which are being tried in this setting. And what are the new drugs which we have in the same setting is the toripalimab and the tislelizumab. So I think toripalimab, some of us have started using in the nasopharyngeal and the esophageal cancers. If this comes here, definitely less toxicity on the pocket for patients. Yes, so it is a doable regimen. We're waiting for the results. So to summarize all the trials here in stage 3 lung cancer, if you see, it is adjuvant. In the adjuvant setting, we have the Keynote 019 pembrolizumab with IM power 010 atezolizumab. And coming to the neoadjuvant, we have the Checkmate 816, that is neoadjuvant nivolumab plus chemotherapy, and adjuvant durvalumab plus chemotherapy in the AGN. And coming to the neoadjuvant, that is perioperative, we have the Keynote 671, and MPAR 030 is also there. Neoadjuvant nivolumab is also there. So these are all the trials in the perioperative, and most of them are approved here. The newer drugs which we are waiting for is the tislelizumab and the sintilimab and toripalimab in the perioperative setting. So to summarize, so as we discussed, we are spoiled for choices, and it's a very heterogeneous subset, as a heterogeneous group, stage 3, and requires all the 3 modalities of oncology to put their brains and decide the best strategy. Early molecular testing cannot be overemphasized, because that decides most of the adjuvant treatments here. And MDT is I think, compared to all other cancers, now in lung, this is becoming more and more essential. Prior decision making and intent is essential in making the right decision in CA lung stage 3. And to choose the right strategy, and sequencing also is important. Thank you very much. I think I can, it was a very big topic. Sorry if I missed few things. We can discuss after this, Dr. Nitya. Over to Dr. Nitya. Thank you.
Thank you, Dr. Vaishnavi. I think a huge topic and a very upcoming important topic has been dealt with really very well. And it is amazing how you put a guideline type of thing here, so that it's very easy for us to go ahead. So can you share a little of your experience on perioperative therapy? I think there are a lot of options now available. And as you said, all of the current immunotherapy drugs have produced immense survival benefit in as perioperative therapy. So how was your experience with perioperative immunotherapy? So how easy is it to use? Easy for the physician as well as easy for the pocket. So as
Yeah.
you mentioned, yeah.
So I think, as you rightly said, if it's easy on the pocket, and then our decision becomes easy. So I have used neoadjuvant nivolumab in 1 or 2 patients, maybe durval in 1 patient. So as you know, maybe overall 3-4 patients we have used neoadjuvant chemoimmunotherapy. Yeah, very good response rates. We're just waiting for how these patients will do in the real world scenario. No new safety signals, or as we were expecting post surgery, the lung issues and all, we have not had it in our practice. But it's a very attractive and a very good strategy. If we convince the patient, and patient is ready to take this, I think it's a very good strategy to go ahead. And you should also have a very good surgical oncology team to support you in these patients. And then it is all these studies included even early lung cancers. So it's important that our surgical colleagues actually have an MDT and say that this benefits. So we start chemoimmuno instead of going right away with surgery. So that also matters in these patients. Yes.
So coming to talk of surgery, I would like to ask the surgical oncologist here, Dr. Sendil, how has the surgery part changed over time? I think we are seeing more number of stage 3 NSCLCs nowadays. So I mean, it was totally not there in our days. It was very difficult to find a non-metastatic NSCLC in the earlier days. So how do you think operability is changing over a period of time, and the other part of the question will be, how easy is it to operate on a patient who has undergone perioperative therapy?
Good evening. Thank you, Nitya, and thank you, organizers, for the opportunity. It's a huge topic, and a lot of it has been addressed already. But my sense on this topic would be this: our threshold for doing mediastinoscopy has changed a lot. That would be the first takeaway, that from a surgeon's perspective. So 10, 15 years back, we would go by more of the PET CT scan findings, or maybe only a CT scan. But now, even if it is N1, we are more, even in an N2 situation, sometimes we are more intent in doing a mediostenoscopy, because we know that it makes a big difference. What we think is N1, 50% of the time it turns out to be a reactive node secondary to a tuberculosis or something else. And what we think even as an N2 sometimes turns out to be a tuberculosis. So tuberculosis is a differential diagnosis. We cannot get away with it. And here, mediostenoscopy makes a big difference. Now, if we look at the latest TNM as well, that has come, the ninth edition that has come, we are talking about single site N2 and multiple site N2. Okay, this is where I feel mediostenoscopy will make the biggest of difference, because the single site N2 will be an ideal case for all these sort of a perioperative chemo and immunotherapy and going back for surgery, compared to a bulky multiple site N2, where surgery, even though feasible, the benefit will be much lesser. And this is something that we will find. And with regards to the question on T4N1, this is a very unique topic that was discussed. So what I would say is, if we have 100 T4 cases, we'll hardly have 1 or 2 N1 cases. Most of them will be N2 or even metastatic at that time itself of presentation. So very, very rare subsite. In selected situations alone, we can operate, because the morbidity of surgery in T4, even though you may get good results, the morbidity sometimes is not worth the effort. We find in very selected cases where we can do some ultra radical resections. That is when we probably select for T4. And even in that situation, we generally give neoadjuvant therapy, see the response. If they are responding well, only then to select. And never, never, never these sort of patients should be selected without an MDT at all, because very, very, very careful selection in T4N1. Most of the time, they will go for neoadjuvant therapy followed by CTRT, or neoadjuvant immunotherapy has come up in a big way. Regarding operating after neoadjuvant immunotherapy, there's something with the lung. My experience in lung with neoadjuvant immunotherapy is little limited, but I have done more of pembrolizumab and nivolumab and other setups where I've done a lung metastatectomy. What we find is, if the patient has a bad lung because of COPD, or a patient already has a tuberculous lung, these patients behave much different compared to a person who is having a native normal lung. So these patients will have a much better recovery compared to a patient with a COPD or thing. In fact, when they have these immunotherapy related toxicity in the pulmonary tissue in the form of an ILD, surgery carries a lot of morbidity. In fact, to get them out of ICU, it's a real difficult job. When we put these staplers for lung resections, when we do these staple resections, sometimes we find these lung tissues so very bad that putting these staplers in itself will tear the tissue. So surgical problems are numerous, and it's very, very important that a patient on neoadjuvant immunotherapy, at every point of time, a small dyspnea is taken very seriously. The pulmonologist is involved. Look at a PFT. If you're talking about re-challenging, you have to be doing it very carefully. These are things that you'll have to keep in mind. Morbidity of surgery is definitely higher, but if you plan everything well, yes, you have definitely have a lot of spectrum for giving a good results in these situations.
Thank you, sir. That was wonderful insight. So I think it's a very different, evolving subset of lung cancer. So I think we'll have a lot of queries in the subsequent days about how useful these perioperative therapies will have, and what is the long-term quality of life. See, every one of the therapies, if it's going to damage the lung tissue, I think it's of significance to actually optimize therapy for such patients. So I have a question to both of you, in fact, to Dr. Vaishnavi first. Do you think PCR is important now? Because we are talking about a lot of PCRs. We say this drug is more, PCR friendly and all those stuff. So do you think that it's going to, I mean, this PCR thing has been always, it's like a wave with a lot of its trough and peaks. So do you think it's going to have any significance in lung cancer per se?
Yeah, so PCR is always attractive to us that, a drug achieves a PCR. But in terms of, I think lung, it is still, I think we are not there yet to say whether PCR is actually getting translated into something like meaningful. But then it is just a proof of principle that, treatment is working. But it is, I think we should, as you rightly said, shouldn't be getting swayed by, the PCR benefits with all the drugs which are giving, and also wait for the primary endpoints, of the studies. And also in immunotherapy and PCR, again, is not something which, it doesn't go so parallelly, like how we see in chemotherapy. It gives some kind of a stable disease, and then it may carry on for many years. So that is something which may not be a a benchmark for treatments which involve immunotherapies. Till then, yes, it is like a proof of principle that the treatment is working, but shouldn't be swayed by just the PCR rates, is what I say.
And
just had one thing with you people, that what about neoadjuvant chemotherapy? When I read for your topic, I said I saw that there is it's not at all recommended, just neoadjuvant chemotherapy before CTRT. So what is your take on this? Are you people doing it, or we still, because in practice we still do it because our radiation colleagues ask us to first give neoadjuvant chemo, and then we see in those patients who are not fit for surgery. So what's your experience? Have you done this?
Yeah, I think immunotherapy is not everyone's cup of tea right now. And
Yes. Yeah.
the drug, which is, of course, the Pembro and Nivo are just now recommended, and they are probably slightly easier on the pocket than Durvalumab. But when we used to see the Durvalumab patients, and whoever was eligible to combine it with chemo and then give it, was too much on the pocket. So for the survival, I think it was very difficult to explain to them that that's going to be the best for them. So I don't think that would be practical in all patients. Yes, we are giving chemotherapy for all of these patients, because many of these are chemo only arms. So we will definitely have that whatever 5 to 10% of benefit, or PCR rates, or maybe the hazard ratio compared to the immunotherapy plus chemotherapy arm. I think we should give that to the patient. And one more thing I would like to ask Dr. Sendil. So what will be your target for operability? How do you assess these patients after the pre-op therapy is over? And what is your target for putting up these patients for surgery?
First, the cardiopulmonary fitness, that matters. It is nice to have an operable tumor, but not a fit patient. Very often after chemotherapy and immunotherapy in an elderly patient who's a smoker, if his lung and heart are not okay, they are not okay for a major surgery. That is the number one thing that you'll have to keep in mind. His performance status and his cardiorespiratory status will be the number one thing to think in mind. The resection that you carry out, generally the trend in a curative resection post chemotherapy, we try to do more lobectomies than pneumonectomies, generally because post pneumonectomies, the problems are multiple. And if you have to have a radiation as well after immunotherapy, then the morbidity is almost unimaginable. So it's very, very important and pertinent that we choose the right select the right patients. So if you do a lobectomy, if at the end of a lobectomy, we'll get a margin negative resection, that will be the ideal candidate, where his remaining pulmonary reserve is good. That will be the ideal candidate. We are not bothered so much about mediastinal dissection in N1 disease, where we can get away without much morbidity. But in N2, the morbidity is a little higher. Okay. So again, the case selection in N2 is based on the response. If the response is pretty good, that is a case we will select for a N2 case for a surgery. Otherwise, these are patients who are having multiple sites of N2 disease or bulky nodes. Even if they respond well, maybe candidates that might go for a radiation rather than a surgery. Case selection is based on what we are going to have, the patient, their disease, and the post-resection status, what we expect. That will be the case selection criteria for me.
Okay, so thank you. I'll bring in the radiation oncologist now into this foray. So how do you, when there is a tri-modality required, so how do you sequence radiation? So that is again one of the important things to know, where to give radiation, whether there is a trial on just preoperative neoadjuvant immunotherapy. So when the patient requires radiation, so how do you time it? How do you sequence it? Right now in the adjuvant, it's either before or after chemo. That doesn't really matter. So how do you sequence perioperative radiation in these, and how long do you wait for surgery to start on? How long do you wait after this therapy to do a surgery? So that is also pertinent now when there is a tri-modality for therapy required for such patients. Dr. Karthik?
Yes, ma'am. So basically, in these patients, sequencing is, my take would be initial chemotherapy. Again, as Madam said, we ask for initial chemotherapy for us to have a better, smaller radiation field and lesser toxicity, and we can also target the particular area for a larger dose and make it amenable for surgery. So after induction chemotherapy, particularly if it is an N2, we would definitely want an induction followed by a CTRT. Because the CTRT, again, the overall survival is better. Again, after CTRT, if suppose the second part is the when can a surgeon take up after radiation is optimal time that I would say for lung patients is 10 weeks, because we do not want more than 10 weeks for the fibrosis to set in after radiation, which would be a very difficult part of the surgery. Before that also, I would say the response of radiation, the benefit of radiation will carry on until at least up to 6 to 10 weeks after the radiation is complete. So the time would be 10 weeks after radiation to take up the surgery.
Okay, thank you so much, doctor. So how important is PDL1 now? So that is one thing that we have to look at, because most of the neoadjuvant or perioperative therapies in other tumors, they require a positivity for PDL1. So how important is PDL1 in lung? We do have patients who have pembrolizumab recommended for any PDL1. So that is also there. There is a trial for that. So how important it is to test for PDL1? So do we do the entire panel, or just tailor it according to the patients? So what is the kind of molecular testing that you would prefer to choose in such patients? And if the PDL1 is negative, how boldly do you go for your choices of immunotherapy?
This is to me?
Yes, doctor. Yes, doctor.
See, if you're, I think EGFR ALK and this thing is very important. So while what we usually do is, as we discussed earlier, we start with those patients who are not for upfront resection, start with the first cycle of chemotherapy, send for, I still do NGS only for these patients to check for EGFR ALK, as we know that, some of these patients, we do smaller panels, or, or just the non-NGS methods we may miss. So we send for an NGS, start off with the first cycle of chemotherapy. And then, if they are positive or negative, depending on that, we plan the chemoimmunotherapy. But as far as PDL1 is concerned, most of the trials now, as we discussed, in the neoadjuvant and the perioperative chemoimmunotherapy, it actually does not matter, as we have checked. It may be in the metastatic setting, definitely it has a role, but in the chemoimmunotherapy, in the neoadjuvant as well as perioperative, I don't think PDL1 will matter too much. Although that is the first one to come in 3 days, for 4 days we have the results. But I think more importantly, we should have the EGFR ALK and the targets, which makes a difference in these patients. PDL1, yes, I wouldn't take it into account when planning chemoimmunotherapy.
Okay. So I think before you joined, we had a case of neuroendocrine tumor. So how is your take on management of neuroendocrine tumors? Do you think the clinical management differs in such patients and treat them differently, or it's just the routine NSCLC run through? I mean, the pure neuroendocrine carcinomas, I think they're treated like one of these small cell lung cancers. But what about the NSCLCs with a neuroendocrine differentiation? Do we treat them differently, or just the same as the other adenomas?
I think with differentiation, I wouldn't change my way of treatment. If it's a pure, as you said, neuroendocrine carcinoma, we treat differently, like small cell. With differentiation, no, I would just stick to whatever. Maybe the response rates and the outcomes may be different, but still the line of management won't change.
Okay, thank you so much. So, so the basic idea is for all of these patients, resectable, potentially resectable, and unresectable NSCLC. So we look for we get a good chunk of tissue. That's very important because we don't know when we'll need it. We don't know when there'll be more stable mutations discovered, so that we can keep the archive tissue for testing later. So we just test them once they're proven to have NSCLC. Go for the genetic testing first. PDL1 really doesn't matter at the moment, because most of these trials that tested were any PDL1, and there is one trial which says more than 1%, but most of it, I think, includes all of these patients with NSCLCs, just like in the metastatic setting. So the EGFR ALK comes first, and then we have the PDL1. Whoever is eligible, give them the perioperative benefit of perioperative immuno and chemotherapy. And immunotherapy is more important now because of the kind of survival and the side effect advantage that it has. And we have a good summary of the kind of surgery and the radiation guidelines that we normally recommend from the surgical and the radiation oncologist as well. So that summarizes around how the sequencing goes. I think we had a lot of interesting case discussions. I would pull in the panelists, the presenters to ask their questions to the panelists. All of them are on board now. So I think you can put forth your questions to the panelists so that they can get your queries sorted. Dr. Neelam, I think you had a few queries on stage 3B.
I have a question for Dr. Vaishnavi. Ma'am, I'm Dr. Ritika. I'm a pathologist from AIIMS Jammu. I just wanted to know that whether you, for EGFR and ALK, you go for IHC or do you directly send the sample for NGS?
Ma'am, we have stopped doing IHC
Mhm.
for these as as a institutional practice. We just do NGS only for these patients. Yeah, because that is the recommended platform. So I don't do IHC, ma'am, personally. But is there any recommendation before starting neoadjuvant? I don't know, but I follow NGS for these markers, ma'am. Yes.
I think it's difficult to partition tissue and send it to different places. So that is also one
Yes.
problem we have.
That's also practical difficulty.
There's one part going for an IHC on
Yes, sir.
pingle one. There's one part going for ALK, and ALK, of course, the earliest to comes within 2-3 days. So earlier we used to say that send for ALK and then sequence and do that. But I think the ALK incidence is very less. So it's more
Yes.
the EGFR that's really important now. In the adjuvant setting, yes, ALK does matter, but the NGS does everything on the same platform, and we have turnaround
Yeah.
times of less than 2 weeks now. I think we
Yeah.
also stopped doing IHC for ALK. It's almost all of it is just the NGS platform. Thank you. So,
Thank you.
any of the from the presentations, do we have any queries from the speakers? I welcome all of you to put forth your queries so that we can get them sorted.
So, yeah, ma'am, this is Neelam. So I have a few questions based on the Pacific trial. So my first question would be, so what is the benefit of durvalumab after the sequential chemoradiation? And then what should be the ideal duration of consolidation durvalumab? And if we can incorporate durvalumab as a concurrent radiation sensitizer, and does consolidation durvalumab work in oncogene addicted non-small cell lung cancer?
I'll take from the last question. In oncogene addicted, if we mean if there are targeted, the driver mutations, no, we don't select these patients for durvalumab. That is one. And it is not for concurrent durvalumab. That is the trial actually checked those patients who did not progress post concurrent CTRT. Those were selected for adjuvant durvalumab in the Pacific trial. So we do not encourage durvalumab during the concurrent chemoradiation. And anything else you would ask? Sorry.
Ma'am, but with the Pacific 2 that has come, and that in that they have incorporated immunotherapy along with the chemoradiation, and the subset did show an benefit in the OS and PFS. So
Okay.
so I just wanted to know that how much, like, is there really a benefit when we kind of give it like we incorporate immunotherapy along with the radiation?
But I don't, durvalumab in Pacific 2, did it show up like a sensitization? I don't think so, but it was included during the chemoradiation. Is that right, Dr. Nitya? I'm not sure about Pacific 2, which has come.
I think it was just a combination of chemoimmunotherapy.
Combination. Yeah. So I think what we are following is approved Pacific trial, which is after those I have seen in my practice also, those patients after you do 6 weeks or 8 weeks or 3 months, when you do a PET CT scan, we have seen progression many of these patients. So for 1 year durvalumab, those subsets are not a favorable subset. So in practice, at present, we are not using the PACIFIC 2 data. We are still using those patients who have not progressed following the PACIFIC trial.
And one more thing, yes, ma'am.
Yeah. Yes. Please go.
And ma'am, in the Pacific 5 that we saw that they tried using durvalumab till progression, but as in Pacific, they've used adjuvant for 1 year. So what is your, what do you think? Like, how long should we really continue durvalumab? Just 1 year is enough, or should we really give it till progression, as we have the data from Laura, in which they kind of gave osimertinib till progression?
Yeah.
So what is your opinion on that?
So these are all, all the trials, they all are arbitrary in 1 year or 2 years, depending on the benefit, cost benefit analysis, the immunotherapy side effects. So these are all factored by these findings. So what we can do is only take takeaways from the conclusions of these studies. So as of now, I think we are following the PACIFIC data of giving 1 year durvalumab. Yes, we have, if we get solid evidence that, it helps in giving progression till progression and the patient is ready to take it, I think we are not there yet as far as the data is concerned.
I think down the years, I think we should be looking at the comparable characteristics of both the trials. I'm sure there will be no head-on trial between durvalumab and osimertinib. So it's never going to be there, because we know that it's like one is oncogene driven, other is not. So we should be looking at people who have similar characteristics so that we can extrapolate from there. So they stopped the trial at 1 year and they found benefit. So if they continue the trial on to 2 years, there might be more benefit. I think this is all going to come up in the next 2 years. How we are just extending letrozole from 5 to 10 to 15. It's just going to be like that. So I think extension of therapies for such immunotherapies, I think it's going to be more and more in the coming years. So it was easy for osimertinib because it's an oral medication. It's not as expensive, maybe. It's almost there, but not as expensive. So it was easier to give up to disease progression. But I think over the period of time, immunotherapy might be extended, is what I feel, until disease progression. And there is also an advantage of the immune system being constantly activated even in the absence of such therapies, because we have anecdotally seen reports where they've stopped immunotherapy and the patient continues to keep responding in the metastatic disease. So all those things should be actually extrapolated into these trials, and maybe we can try and extend. So the only problem here is there is no disease. So what do we monitor? So that is the only problem with immunotherapy. And so I think time will answer those questions. We might have some meta-analysis later where we look at so many kinds of trials that have been used, and probably we'll have an answer then.
Yeah, as you said, the comparison cannot be done on an oral drug and IV drug. We consider a lot of QOL issues also in these trials. And if you see the imatinib trials, we are coming down on the duration. So such until we have such solid results, I don't think we can extrapolate the same data. Yes.
And ma'am, what is your opinion on like doing a ctDNA and checking that, and depending on that, if we can really continue like the durvalumab, the duration, like how long to continue on that? So what's your opinion on the ctDNA clearance and all of that, ma'am?
I don't know about the durvalumab, whether we can continue, but then we have started doing that in the colon as such in our institute. When metastatic colon also, we just doing a study at 0, 6 and 12 weeks. We're doing that in adjuvant setting to decide in stage 2 whether we should give chemotherapy or we should stop at 3 months chemotherapy. So these are the settings which we are doing in stage, in colon cancer. As far as lung is concerned, I think that's an exciting area of research right now. ctDNA is coming out, ctDNA based personalized treatment, and also based adjuvant and continuation of the therapies. Yes, I think over time we have to wait and watch and incorporate ctDNA also.
I think there are many trials looking at ctDNA measurements in many of the solid tumors. I think it just clicked in colon. We'll have to just tweak our results to breast and, or whatever is ongoing. The only problem with ctDNA is in lung is because we don't have too many early lung cancers, like how we see in the West. We don't have a proper screening protocol. We don't have a proper early diagnosis. So once you have an early diagnosis and more of adjuvant treatment going in, I think that's where the ctDNA really helps, rather than looking at how they responded in the metastatic setting. We have imaging for that. So I think more of early lung cancers being detected will lead to more of ctD. And we've not been very successful in breast as well in that aspect, because we see a lot of early breast cancers. I think we have a long way to go for lung, but I think we will reach there eventually. So.
Yeah, there are also studies done on dynamic monitoring of VAF on certain signatures, for example, RAS in colon and EGFR also in lung. So these are all upcoming studies. That's a area of research, definitely. I think today's students may be practicing that in the next 3 years or 4 years. Yes.
And ma'am, my last question would be, for a stage 3 resectable non-small cell lung cancer, so we started with a neoadjuvant approach, like neoadjuvant immunotherapy, as we saw the Checkmate 816. And after the neoadjuvant immunotherapy, we went ahead with the surgery, and the patient did not attend PCR. So what would you like? I mean, it was not a PCR in the surgery. So how would you go? I mean, what would be your adjuvant plan regarding that patient? How would you go ahead about it?
Yeah, so that's why I mentioned that these plans should be an upfront decision. If you are going with a neoadjuvant chemoimmunotherapy, you stop at 3 cycles of nivolumab, irrespective of whether you achieve PCR or not. So you don't give adjuvant, immunotherapy just because the patients, they didn't achieve PCR or otherwise. So it should be an upfront decision what you're going to follow. I think most of the studies have shown similar results. What I would follow is a simple one, because 3 cycles of nivolumab, which looks practically feasible to me to do for the first 3 cycles. Or you can follow a perioperative durva or any other, based on, basically these are all controlled by what is the economics of this thing, but the results are all similar. If you see across all the studies, results are similar. So what suits the patient and tailored to that we should do, and it should be based on your upfront decision. So you should not change the decision at after surgery whether there is a PCR or not, because none of this was stratified based on what was the pathological response.
I think that is very important. Again, a take-home discussion, a take-home message, because this is a curative intent. So we definitely need a plan on day 1 of starting therapy. So we can't go away from it unless there is some unexpected change in the response, or there's any progression. So when everything's going as per plan, we need a plan first. So a multidisciplinary team is needed to find that and charter that plan and then get it done. So very important decision that. So thank you. I think any more questions? There are any more? I think we can just answer. Else we can close the session.
Any role of radiation post neoadjuvant chemo or neoadjuvant chemoimmuno in NSCLC? Like in stage 3 only, which like post neoadjuvant chemo or post chemoimmuno, like nivolumab or durvalumab, post that any role of RT, which is like, if we thought like it is a curative intent but still inoperable.
Dr. Karthik,
Yes.
I think you can take that question.
Yeah, if it is still inoperable after neoadjuvant chemo or immunotherapy, we can still go for a preoperative dose of radiation, and then hand it over and then check if it is becoming operable after 3 months after radiation. So the pre-op dose, we don't go up to 60 or 70 as we go for the definitive cases. We stop at 25 days of 45 degree of radiation. We can still see the response, but usual dictum is when it is responded a little lesser to chemo or immunotherapy, the response radiation will also be on the lesser side, but still our aim is to make it amenable for surgery. So there is a
Post RT, sir, to continue adjuvant, because most of the trials with surgery, they've continued adjuvant immuno also. Post RT, whether to consider to continue or to stop at that level only.
If it is amenable for surgeon to operate, I think surgeon can take it up. Otherwise, I think further adjuvant therapy should continue from the chemo.
Yeah, just if it's not operable, just goes like a maintenance, and we just follow up after that point in time. I think that answered the query. So thank you, everybody. I think if there are no questions, I would like to thank my speaker, Dr. Vaishnavi, for spending so much time, explaining such a big topic, summarizing it well, and answering all the queries. My panelists, Dr. Senthil and Dr. Karthik and Dr. Ritika, so they've really spent some time answering all the queries that were put up by the presenters. And to my case discussants, all the postgraduates and the junior consultants who have we have come up with their own cases and tried to discuss in this forum. This is not an easy topic because we know that there are it's a rare incidence to see a non-metastatic NSCLC, although the incidence is increasing now because of better diagnostics and better symptomatology management. So I think they've done a wonderful job bringing forth so many cases for discussion, and I'm sure all of you benefited from it. Thank you, speakers. Thank you so much, and thank you, organizers, IAIO, for this particular series. I think it is helping people a lot, and we expect to have more number of case discussions in the next few sessions. We have our next sessions in next session on August 22nd, and it is on prostate cancer. So we will give you information about the case so that you can get ready with your cases earlier. It is also a very interesting topic to discuss because there are a lot of recent advances in it, and just get ready with your cases in the next 2 months. I think we will have a wonderful discussion like how we had today. Thank you, everyone, and thank you, IAIO, for this session. And even my knowledge was totally refreshed today from all the discussions that happened. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, ma'am. Thank
Thank you
you.
so much, ma'am.
Thank you.
For all the participants, the certificate will be shared to your register mail IDs in 7 to 8 working days. We have sent our LinkedIn page and our WhatsApp community where you will be knowing our upcoming events. Thank you.